We all know what a scab looks like, that hard crust over a cut. And we usually think, okay, it's healing. That's a good sign. But here's something that might surprise you. Sometimes that very layer and other kinds of dead tissue actually, well, it needs to come off for proper healing to happen.
That's a really important point, and it leads us right into what we're digging into today. Wound debridement. We've been looking closely at the chapter covering this in Wound Care Essentials, practice principles, and honestly, it's just fundamental, really fundamental.
Exactly, debridement. It might sound technical, but basically it's just removing tissue that's, well, dead or not viable from a wound. And it's not just cosmetic, it's actually critical. It can be the difference between a wound healing well or, leading to some serious problems. So if you've ever dealt with a tricky wound or helped someone who has, understanding this process, it really shines a light on how complex wound care can be.
So our goal today really is to explore why removing this tissue is so crucial and how clinicians actually identify the different kinds of tissue involved, plus situations where maybe debridement isn't the best idea,
Right.
and then cover the different methods they use. There are quite a few, and how they choose the right approach for each specific wound.
Okay, let's start with the why. Why is getting rid of this non-living tissue so vital? What happens if you just leave it there?
Well, think of it like this. That dead tissue, it's a constant irritant. It keeps triggering inflammation, which can just halt the healing process in its tracks. But maybe even more importantly, it's basically a feast for bacteria. Yeah, it becomes a perfect breeding ground. And not just any bacteria, but potentially those really tough communities called biofilms.
Right, those are notoriously hard to treat.
Exactly. They're like little shielded cities for bacteria.
Yeah.
So removing the dead tissue helps get the bacterial numbers down on the wound surface. And that drastically cuts the risk of deeper infections spreading, things like cellulitis, which is a skin infection, or even osteomyelitis.
Bone infection.
Bone infection, right. Or septicemia, that's a dangerous bloodstream infection. In the worst cases, leaving that tissue can lead to amputation or even be life-threatening.
Wow. So it's not just a physical barrier then. It's actively removing a source of danger. That makes a lot more sense.
Precisely. And another thing, clearing away all that non-viable stuff gives you a clear view of the actual wound bed. Think about a pressure injury covered in dead tissue. You can't possibly tell how deep it is or what stage it's at. Debridement lets you see what's really going on.
So you're clearing the way, almost literally, for the body's repair crews to get in and work effectively.
That's a great analogy. Yeah, you're essentially turning a chronic wound environment back into a more acute one. And this helps improve the delivery of oxygen and nutrients through the blood supply, both absolutely essential for building new tissue. At the cellular level, think about it. In low oxygen spots, bacteria are fighting hard for the limited nutrients.
Right.
By removing the dead tissue and helping oxygen get in, you reduce that competition. It creates a better environment for the key cells, fibroblasts, to move in and start making collagen the scaffolding for new skin, basically. That's how you get healthy granulation tissue.
Like weeding a garden so the good plants can actually thrive.
Perfect analogy. Now, in healthy folks, the body often has its own cleanup crew, its own natural debridement processes. But if someone's immune system is compromised, maybe due to poor nutrition or conditions like diabetes, that natural process might not be enough, that's when medical intervention becomes necessary.
Okay, so we get why it's needed, but how do you actually tell the difference between tissue that's okay and tissue that needs to go? What does this necrotic tissue actually look like?
Good question. There are two main types clinicians look for, eschar and slough. Eschar is often what people picture as a scab, but usually it's thicker, tougher. The book describes it as dry, firm, leathery, usually black. It often happens when wound tissue gets dehydrated. But here's a really critical point about eschar. Sometimes it can hide an abscess, a pocket of infection underneath. So just looking at the surface doesn't always tell the full story.
Like a dark shield that could be hiding trouble underneath. Got it. What about slough? That term comes up a lot.
Slough is quite different. It's typically soft, loose, moist. Color-wise, it can be yellow-green, even gray sometimes. It's basically devitalized tissue that's lost its blood supply. It might be just loosely draped, or it could be stuck on more firmly. Now, there's been some, scientific debate about exactly what slough is. Is it true tissue or more like an inflammatory byproduct? But honestly, the clinical consensus, backed by groups like the European Pressure Ulcer Advisory Panel, is pretty clear.
Which is?
Regardless of its precise origin, if you've got slough in a wound you want to heal, It's acting as a barrier. It can harbor bacteria. It
Yeah.
needs to come out. Simple as that.
So bottom line, it's not helping. It's probably hindering. Get rid of it.
You got it. Neither eschar nor slough lets that vital oxygen and those nutrients get through to the healthy tissue underneath. And like we said, both can be a haven for bacteria. Removing them is step one towards creating a healthy healing environment.
Okay, so generally, removing this stuff is good. But you mentioned earlier, there are times when debridement is actually not the way to go. That seems counterintuitive.
It does, but yes, there are definite situations where you need to be really cautious or even avoid debridement altogether, or maybe just do it very conservatively. A big one is if the blood supply to the area is severely compromised, or if the patient is significantly immunosuppressed, their immune system is weak.
Right.
In those cases, aggressively removing dead tissue from, say, an ulcer could actually make things worse. You might consider a very gentle, what's called conservative sharp debridement if it's absolutely necessary, but with extreme caution.
Because if the body doesn't have the resources of blood flow, the immune cells making the wound bigger might just prevent it from healing at all.
Precisely. And what about those stable, hard, black eschars you sometimes see on heels, particularly in older people?
Ah, yes.
If they're truly stable, meaning hard, dry, no signs of infection, like redness, swelling, pain, drainage, they are often not debrided.
Why not?
Because on the heel, there's often very little padding over the bone, the calcaneus. Removing that stable eschar might expose the bone, and if the blood supply isn't great, that exposed bone is a very serious problem that might not heal.
Okay, that makes sense. Protect the bone.
And this is crucial if there's any suspicion of infection under or around that heel eschar.
Like what kind of signs?
Maybe a bad odor, swelling, redness spreading, tenderness if the patient can feel it, any fluid leaking out, maybe even a crackling feeling under the skin, which is called crepitus.
Gotcha.
Any of those signs, then that eschar must be carefully removed to see what's going on underneath and treat the infection. And of course, with any ulcer on the leg or foot, assessing the patient's vascular status, their blood flow is absolutely essential before you even think about debriding.
So it's a real balancing act, especially where circulation is poor or there isn't much tissue. Any other specific conditions where you'd hold off?
Yeah, pyoderma gangrenosum is a key one. It's a nasty inflammatory skin condition. It typically has this raised purplish edge, and the center just rapidly breaks down into an ulcer.
Good.
The tricky thing here is that any kind of trauma, including surgical debridement, can actually make it worse. It triggers more inflammation. It's a phenomenon called pathergy.
Wow, so trying to help actually flares it up.
Exactly. Now, the text does mention some rare complex cases where really aggressive surgery followed by specialized treatments worked, but generally you avoid debriding pyoderma gangrenosum.
Fascinating. Anything else?
And finally, if someone has septicemia, a serious bloodstream infection, you generally hold off on wound debridement until they're getting effective systemic antibiotics to treat that main infection first.
Okay, so deciding if and when to debride is a really critical first step, even before you think about how. What guides that initial decision?
A fundamental starting point is categorizing the wound based on its healing potential. Is it healable, maintainable, or non-healable?
Okay, what defines healable?
Healable means two key things are in place. Number one, there's enough blood supply getting to the area. And number two, the underlying cause of the wound can actually be treated or corrected.
For example?
Like for a venous leg ulcer, you can use compression therapy. For a diabetic foot ulcer, you can offload the pressure. For a pressure injury, you address the pressure, nutrition, mobility issues. If you can do those things and the blood flow is good, maybe you can feel a pulse in the foot. Or tests show good circulation, like an ABI over 0.6, then active debridement to get rid of all the dead stuff is usually the way to go.
Okay, what about a maintenance wound? Sounds like it's kind of stuck.
Pretty much. A maintenance wound usually has decent blood supply, but something else is stopping it from healing properly. It might be patient-related factors, maybe difficulty sticking to the treatment plan, or other health issues that are hard to manage. In these cases, debridement is usually more conservative. You focus on removing loose slough, but you're not necessarily aiming to get down to bleeding tissue like you would in a healable wound.
And then the third category, non-healable. What's the approach there?
Right, for non-healable or palliative wounds, the blood supply is just too poor, it can't be fixed, and the cause can't be corrected. So the goal shifts. You're not really aiming for full healing anymore. Debridement here is very conservative, maybe just removing easily detachable slough. The focus is more on managing symptoms, using topical antimicrobials, keeping moisture in check, reducing bacteria, basically preventing complications rather than closing the wound.
So the overall goal for the wound really drives the debridement strategy. Makes sense. You also mentioned the dime time model earlier.
Yeah, DIME, or TIME as it was originally known, is just a useful framework clinicians use for wound bed preparation. It's an acronym.
That's for.
Debridement, infection and inflammation management, moisture balance, and edge management dealing with unhealthy wound edges. It's just a good checklist, really, to make sure you're addressing all the key factors needed for healing, and debridement is often that crucial first D.
And it's not just about the wound itself, is it?
Yeah.
The patient as a whole person is central.
Oh, absolutely. Patient-centered care is everything. That means really explaining things to the patient and their family. What's the point of debridement? Why might the wound look bigger at first? It's not removing a simple scab.
Managing expectations.
Exactly. And getting informed consent, especially for something like conservative sharp debridement where there's more risk of bleeding, that's vital. And of course, a big one is managing potential pain.
Yeah, pain must be a huge concern for anyone facing this.
It definitely can be. So assessing and managing pain is a critical part of the plan. That could mean using topical numbing creams or maybe systemic pain relief, depending on how much debridement is needed and the patient's tolerance.
And where it's being done matters too.
For sure. Debriding in an outpatient clinic versus an operating room offers different pain control options. And it's so important to remember even patients who can't communicate verbally, maybe due to advanced neurological conditions, they can still feel pain. You have to watch for nonverbal cues.
These are all really crucial things to sort out before you even pick up an instrument. Okay, now let's get into the how. What are the main ways clinicians actually remove this non-viable tissue?
The text lays out several main categories. There's mechanical debridement, sharp or surgical debridement, enzymatic debridement, autolytic debridement, and even biological debridement.
Which includes maggot therapy, right? Always fascinating.
That's the one.
Okay, let's start with mechanical. What falls under that?
Mechanical means using some kind of physical force. Think wet to dry dressings, hydrotherapy like whirlpools, and wound irrigation, sometimes with pulsed lavage systems. The main thing about mechanical methods is they're generally non-selective.
Meaning
They can rip away healthy, new granulation tissue along with the dead stuff, and they can often be pretty uncomfortable, even painful.
wet to dry dressings. That's the classic sticking moist gauze on, letting it dry, then pulling it off, taking tissue with it.
That's the one. And while it sounds simple, maybe cheap, it's got real downsides. Like you said, it hurts. It pulls off that good granulation tissue you want to keep. Plus, it needs frequent changes, so it's time-consuming.
Yeah.
Because of all that, and because we often have better, more selective moist wound healing options now, guidelines from groups like Medicare actually limit using wet to dry, especially on clean wounds that are starting to granulate. You might still consider it if there's a lot of dead tissue, and surgery isn't an immediate option, but it's used less often now.
Okay. What about whirlpools and pulse lavage?
Whirlpool hydrotherapy can help loosen surface debris. But you need special equipment, and there's a definite risk of spreading bacteria around if you're not super careful with cleaning and protocols. Pulse lavage uses a device that shoots pulses of fluid at the wound while sucking the fluid and debris away. It can be better at removing loose stuff and might even stimulate granulation. But again, you need the equipment, the patient often needs pain meds beforehand, and there are risks like potentially driving bacteria deeper or creating aerosols, so staff need proper PPE.
So logistical hurdles and infection risks mean it's not a common go-to in everyday practice.
Generally, no, not for routine wound care.
Okay, so mechanical methods have their place maybe, but with significant drawbacks. What about sharp or surgical debridement? Sounds much more direct.
It is. Sharp or surgical is often seen as the most efficient, the most precise method. Many consider it the gold standard, really. It involves using sterile instruments, scalpels, curettes, forceps, scissors, to physically cut away the non-viable or infected tissue. There are also more advanced tools like ultrasonic debriders, hydrosurgery devices, even lasers sometimes.
Does it hurt?
It can, yes. So local anesthetics, sometimes even regional blocks are often used. The big advantage is speed and selectivity. A skilled clinician can very precisely remove only the bad tissue, leaving the good stuff behind.
You mentioned needing excellent clinical judgment. Why is that so critical here?
Because you're cutting tissue,
Yeah.
you absolutely have to know what you're looking at. For instance, a tendon might look yellowish, but so can slough. You need to tell them apart. Big difference in how you treat them.
Absolutely.
You need to identify that line between living and dead tissue, the demarcation line. Sometimes you even need to debride slightly into the seemingly non-healing edge to wake up the healthy cells. Some clinicians might even use a dye like methylene blue to help highlight non-viable areas.
And there are different intensities of sharp debridement. You mentioned conservative versus surgical.
Exactly. Conservative sharp debridement usually means just removing loose, non-viable stuff with minimal bleeding, often done by trained nurses or therapists. Surgical or excisional sharp debridement is more extensive, typically done by physicians, surgeons. The goal there is to cut away all the non-viable tissue right down to healthy bleeding tissue, basically converting that chronic wound into an acute one.
And that more aggressive approach, getting down to bleeding tissue, that's shown to be beneficial.
Yes, studies, particularly with diabetic foot ulcers, show it can significantly improve healing rates. It removes not just the dead tissue and bacteria, but also those old, slow-healing cells, the senescent fibroblasts.
And this helps with biofilms, too.
Yes, sharp debridement is good at physically removing biofilms. The catch is, biofilms can come back surprisingly fast, sometimes within 6 hours. So after sharp debridement, using dressings like calcium alginate is helpful. They can manage the bleeding and keep things moist for healing without forming a hard crust. Oh, and a really important point. You have to be extra careful doing sharp debridement if the patient is on blood thinners.
Right, makes sense. Okay,
Yeah.
so sharp surgical is effective, precise, but needs real skill. What about enzymatic debridement? Using creams or ointments?
That's the idea. Enzymatic debridement uses topical products that contain specific enzymes. These enzymes literally digest the necrotic tissue by breaking down proteins like collagen and elastin that hold it together.
How does that compare?
It's generally considered safe, effective, and pretty easy to apply. That makes it a good choice for patients who maybe aren't surgical candidates or for use in long-term care or at home. It's also good for wounds needing gradual, ongoing debridement over time.
How is it actually used? Just spread it on.
Pretty much. Usually applied once a day directly onto the dead tissue after cleaning the wound. Sometimes, if you have thick, dry eschar, you might do something called cross-hatching, making little shallow cuts in the eschar first, if there's no infection suspected underneath, to help the enzyme penetrate better.
Okay.
One thing to keep in mind is that as the enzyme liquefies the slough, that soupy stuff could potentially feed bacteria. So often, these enzymatic agents are used along with some kind of topical antiseptic dressing. There are different enzymes, proteolytics, fibrinolytics, collagenoses. Collagenase is particularly interesting.
Why is that?
It's thought to be more selective. It mainly targets the type of collagen found in dead tissue, while sparing the healthy stuff. So it might be less painful, and some evidence suggests it might even help stimulate skin cell migration and granulation tissue growth.
Are there things you need to watch out for when using enzymes?
Yes, definitely. Some things can inactivate the enzymes. Silver is a big one, and other heavy metals like zinc oxide, sometimes found in other creams or dressings. So you have to be careful what you use alongside it.
Good tip.
Also, these are prescription products. You need a doctor's order. And it's important to really clean the wound well before each application to get rid of any old ointment and loose bits. Research suggests collagenase can be faster and maybe more cost-effective than some other methods, and as I said, might help keratinocyte growth, which is key for closing the wound.
Okay, so enzymatic offers a targeted, often gentler chemical approach. Now, autolytic debridement, that sounds like it uses the body itself.
Exactly right. Autolytic debridement harnesses the body's own natural enzymes. These are already present in the wound fluid. They work to slowly soften and liquefy the necrotic tissue. Then the body's own cleanup cells, macrophages, come along and gobble up the debris.
So is the body doing the work?
It is. It's much slower than sharp or enzymatic methods, definitely more gradual. But it's generally seen as the most selective, it doesn't harm healthy tissue, and often the least painful, especially if the blood flow is good. The main drawback is speed, and it's generally not suitable for heavily infected wounds where you need to get the dead tissue out quickly.
So how do you actually make autolytic debridement happen?
You facilitate it by using moisture-retentive dressings, things like transparent films, hydrocolloids, hydrogels, calcium alginates. These dressings trap the wound's natural moisture, the exudate, against the wound bed. That fluid contains the enzymes, and keeping it there allows them to work.
Makes sense. Create the right environment.
Exactly. Studies have shown hydrogels can be more efficient and cost-effective than old-school wet-to-dry for this. And moist dressings in general can work about as well as collagenase enzyme ointments in some cases. Hydrogels also seem better than plain gauze for diabetic foot ulcers using autolysis.
What do patients need to know if they have this type of dressing?
It's important to tell them that seeing some fluid buildup under the dressing is normal. That's the process working. But they also need to know the signs of infection to watch out for: increasing odor, change in the amount or color of drainage, redness spreading, warmth, more pain. Any of those, they need to get it checked out, and the strategy might need to change.
Okay, gentle, slow, uses the body's own power. And that leaves us with maggot therapy. Still feels a bit sci-fi even though it's old.
It does have that reputation.
Wow.
But biological debridement using sterile maggots, specifically the larvae of the green bottlefly Lucilia sericata, has actually seen quite a resurgence, especially in Europe. It's a recognized tool.
How do they actually work? Just eat the dead stuff?
It's more sophisticated than that. Yes, they ingest necrotic tissue, but they also secrete special enzymes, proteinases, that actively break down the dead tissue first. And they don't just eat tissue, they also digest bacteria, including really tough ones like MRSA, and even fungi like Candida albicans.
Wow.
Plus, their activity seems to stimulate the growth of healthy granulation tissue.
So they're debriding, disinfecting, and promoting healing.
That's the idea, yes. Studies have shown they can debride effectively and quickly, reduce wound size, and in some difficult cases, potentially help avoid amputation or stop bacterial spread.
Are there times you wouldn't use them?
Oh, definitely. Contraindications include wounds that are immediately life or limb-threatening, if the patient is extremely distressed by the idea, if there are serious bleeding problems, or in deep tunneling wounds where you can't be sure you can get them all out. Use in osteomyelitis or severe ischemia is still debated.
What about cost and patient acceptance?
It can actually be quite cost-effective in the right situation. And while some patients are understandably hesitant at first, studies have reported decent patient and provider satisfaction.
Does it hurt?
Reports are mixed. Some patients feel very little, maybe just a tickling. Others do experience pain and need analgesics. Neuropathy, nerve damage can obviously affect pain perception too.
Fascinating how an organism can do all that. Okay, so we have this whole toolkit. Mechanical, sharp, enzymatic, autolytic, biological. How on earth does a clinician choose the right one? So many variables.
You're absolutely right. It's rarely black and white. It's a complex decision based on weighing up a whole host of factors. Number one, always, can the wound actually heal? Is the blood supply adequate? That's foundational. Then, has the underlying cause been dealt with? Pressure offloaded, infection treated, etc.
Right.
Then you look at the wound itself. Size, depth, location, how much drainage, what kind of drainage, signs of infection, what caused the wound in the first place. How quickly does a debridement need to happen? Is there time for a slower method like autolytic, or do you need the speed of sharp debridement?
Okay.
Clinicians also have to consider regulations. What are they allowed to do in their state or facility? What training do they have? How selective does the method need to be? Do you need to protect delicate structures nearby? Where is the care happening? Hospital, home, clinic? And ultimately, how much debridement is enough? When do you stop? Usually the goal is a wound bed fully covered in healthy granulation tissue, no necrotic stuff left. Sometimes using that methylene blue dye can help confirm you got it all.
It really sounds like a deeply individualized puzzle for each patient and wound.
It absolutely is. There are even research tools like the Debridement Performance Index, used to try and objectively measure how well the job was done. And this idea of serial debridement is important too.
Meaning doing it repeatedly.
Yeah, especially in chronic wounds. Doing frequent, maybe smaller debridements can help keep that bacterial load down consistently and continually stimulate those growth factors needed for healing.
The chapter you looked at included a patient example, didn't it, to kind of tie it all together?
It did, yeah. A really helpful scenario. It was a 55-year-old woman, type 2 diabetes, neuropathy, pain in her big toe, which was worse in shoes.
Okay.
So first steps: manage the underlying issues, get her blood sugar under better control, address her pain. The exam found a thick callus on her second toe needing debridement, and the painful ulcer on the big toe actually probed right down to the bone. X-ray confirmed osteomyelitis, the bone infection. Good news was, her blood supply seemed okay.
So what was the plan?
Local wound care involved sharp surgical debridement, getting rid of that callus, dealing with any dead tissue around the ulcer, and addressing the infected bone. They used a calcium alginate dressing afterwards to manage bleeding and keep it moist. The case really illustrates that VIPS mnemonic they mention.
Remind me.
Vascular supply check, it's adequate. Infection treat it, she got oral antibiotics. Pressure offload it, she got a special walker boot and orthotics.
Hmm.
And sharp surgical debridement, which included dealing with an ingrown toenail that was likely part of the problem.
Oh, the cause.
Exactly. And it also highlighted that she'd likely need ongoing maintenance debridement to manage recurring calluses because of her neuropathy.
That really brings it home how you have to tackle everything, the systemic stuff, the symptoms like pain, and then the targeted local wound care, including the right kind of debridement. They all have to work in concert.
Precisely. Debridement isn't just this one-off thing. It's a key piece within a much broader, individualized wound management strategy.
So, wrapping up our deep dive today, it's really clear that wound debridement is, well, way more involved than just cleaning things up. It's a critical, complex process, absolutely vital for allowing proper healing to actually occur.
Yeah, it really is. It's nuanced. It requires really understanding the different types of tissue, knowing when not to debride, and having a grasp of all these different methods available. Making those informed choices about when and how is just essential for getting the best results in wound care.
And like we've heard, it's definitely not always straightforward. It takes careful assessment, weighing multiple factors unique to that person and that specific wound.
Exactly. And it really makes you appreciate the science and skill involved in something that might seem quite basic, like caring for a wound, how medicine supports the body's own amazing healing powers.
It does. And thinking about all the layers involved just in debridement, it makes you wonder, doesn't it? What other common medical procedures have this hidden depth, this complexity that we maybe don't fully realize?